you told us about Trellis and mentioned ECOS catheter, ultrasound assisted. I just wanted to get your opinion on what you feel about the ultrasound assisted catheter, because I found that especially in trying to limit it on a same session approach, really I haven't been very impressed with it, because the Trellis works much better in getting short-term results. The ECOS maybe wants you to get overnight lysis more often.
So the question of what's the utility or the advantage of using the EcoSlicer system? The current generation of the device that's available, its utility is probably very limited. Even the studies that's conducted and sponsored by ECOS and DVT showed that you may cut the duration of infusion for just 1 or 2 hours, which doesn't make any practical difference. My guess is if we did a randomized study in DVT, we'd probably not see any difference. The next generation devices, they have technologies that can cut the duration to about 4 hours. It's not marketed, it's not out there yet, the studies are not done. Hopefully with the acquisition of the company by their new parents, that they would put that system into work and we'll see it clinically. The current system, I don't think that it adds much except cost.
And are you routinely putting IVC filter before you initiate catheter-directed thrombectomy?
No. For catheter-directed thrombolysis, unless it's a mobile clot in the IVC, there is no benefit in placing filters. That has been shown in multiple studies. Just adds cost and time. No difference in PE rates. Just an interest, just while we're waiting, just a quick comment. 85% of the filters in the world are used in the United States alone, and most of this on the East Coast of the United States. The incidence of pulmonary embolism or deaths from pulmonary embolism per capita or per admission on the East Coast and West Coast of the United States is the same. And the rate of utilization of filters between East Coast and West Coast is 10 to 1. So that gives us a pause as to the utility of filters.
Good morning. Doctor, can you elaborate more on the indication for the thrombolytic and the mechanical thrombectomy, like in chronic situations sometimes, and like in retroperitoneal fibrosis with the caval or iliac lung disease, and with the little symptoms sometimes, or little swelling, and the patient is not, have a lot of complaint, versus the clear indication like the phlegmasia, which is really clear indication. We're talking about the gray areas, for the approach.
If I understood the question correctly, the indications for thrombolysis or mechanical thrombectomy devices in subacute or chronic venous occlusions, there's none. It doesn't do you any good. Those situations, especially the chronic ones, is basically recanalization, angioplasty, followed by stenting in non-dialysis patients. Nothing else works so far. In acute setting, obviously you have to get rid of the clot. As I mentioned earlier, the CAVAN trial, which was a randomized study just published a couple of years ago, also confirmed what we had seen in single-center studies, that the residual clot, even with flow, the patient's rate of rethrombosis is high. So those are the patients that actually benefit from stenting.
Actually, I have a comment. Dr. Bertolucci lectured about the central axis. I am amazed that we have little PICC lines services done in this region. Now, when I came to King Faisal 10 years ago, I suffered a lot, but then we started this, and it's the PICC line. I found the PICC line service not only helped my patients from these central lines and infection rate and mortality, but also it helped me as an interventional radiologist, that I had the administration and look at me, and they give me more support, and I have more staff, and then I could expand and help patients. Now, how can we spread this knowledge and this culture of starting? I mean, this is an easy thing to be done, but how to motivate doctors from going to all doctors here, they want to do the stenting, the embolization, big procedures. But they look at the central venous access, that's a small thing, not very interesting. So how to change this attitude?
Well, we have not really a problem about this. Quite unexpectedly, our anesthesiologists and our radiologists were happy that somebody else was doing the dirty job, meaning that the interventional radiologist makes such delicate procedures, such important procedures, and the number of procedures of the interventional radiologist is increasing every day, every year. You invent new things to do so that something can be done by another professional figure with the lower cost, etc. I mean, the radiologist will accept that. Even the anesthesiologists, in our country there is a shortage of anesthesiologists. I don't know here. And so the anesthesiologists have many different tasks in the hospital. So they accepted quite well. There was not this, culture shock of saying, oh, no, a nurse should not do it. I mean, they were happy that somebody else, especially when they saw the results were very good.
Yeah, actually, there's nobody else doing it. You know what I'm saying? It's not like we don't have IV. In most hospitals in this region, not only Gulf countries, but Iran, India, and in the whole region, you will find very few centers with venous access teams. So my theme, and as you know, to the interventional radiologists, that they can, as I did, I started this, and then I taught the nurses. Now the nurses do it bedside. They report to me. It's my work, but I train them. They're my team. They don't do it in the angio suite most of the cases, only the difficult cases. But this add to my numbers, my domain. So I am asking, actually, we even discussing in the Paris to start vascular access or PICC line services programs to be developed in the region and to be led by specialized doctors and interventional radiologists and and trained nurses. So it's just a message that this is a thing that you can add to your service. You can help a lot of patients, and it's very crucial and very simple to be done.
Mm-hmm.
Thank you.
Yeah, thank you for that comment. If you want to take my advice, the best thing is to start with a mixed, multi-professional, multidisciplinary team with both doctors and nurses and doctors coming from different area of competence, such as one radiologist, one infectivologist, one anesthesiologist. That would be a good advice from our experience. Thank you.
Okay, thank you. We're going to wrap